Hello, my name is Shia Ritchie, and I'm going to um, demonstrate how to perform a vaginal examination to assess labor progression. So, during this examination, I will assess cervical dilation, cervical effacement, fetal station, and fetal position. Disclaimer, I think my pelvic model is in my storage unit because we just moved to this apartment. So I am going to use my daughter's play cup. We'll pretend that the top part is the pubic symphysis and this part is the sacrum, which I feel like makes it a little easier to tell which, like the anatomical positioning of the pelvis. So before I begin, with the client, I review the indication for the examination. I receive consent. I explain the procedure, and then I answer any questions that the client may have. And then I also assure privacy and dignity are maintained, so making sure that the people in the birthing room are the people that they are okay with witnessing a vaginal exam. Obviously, before starting, I would put on sterile gloves, and then I'd get lubricant on 2 fingers, making sure that nothing else touches the 2 fingers before I do that. If the client is in the water, I'd probably forego the lubricant, but I'm still putting on the gloves. So the patient's going to be positioned either supine in bed or just comfortably on like their butt if they're in the tub, with their legs up if they can. I will apply the sterile glove and use the lubricant on the examining finger. So I'm right-handed. It's going to be my index and middle finger. So I would insert my index and middle finger into the vagina, and I position the fingers posteriorly and slightly downward initially to follow the natural curvature of the vaginal canal. And then I'm going to advance my fingers and assess the vaginal walls and continue until I locate the cervix. So I'm going pretty deep inside, and make sure you're like telling the client, okay, I'm going to go a little deeper. Here's my touch. And then like breathe. I'm going to go a little deeper because sometimes the client may clench. Sometimes they're having a contraction. So it's just good to tell them like what you're doing. Then you tell them that you identified the cervix, and so we're assessing for dilation. Let's just pretend that this client is in their second hour of active labor. So in the example, the cervix is probably like 5 centimeters dilated. Obviously, the client's asking for a vaginal exam, so they're probably a little exhausted, but it's possible that not a lot of progress has happened so far. Let's just have that client scenario in our head. If the cervix were fully dilated, I wouldn't be able to feel a cervical rim around the presenting part, and that, if I did, that would indicate that the client's fully dilated. So next we assess effacement, which refers to the thinning and shortening of the cervix during labor, and that's typically presented as like a percentage. So we're palpating like thickness, but also like in a client who's in active labor, we're really assessing the thinness. So example, if the client might feel like 80% effaced, which is like a very thin, but not like paper thin cervical wall. So now we're assessing fetal station, and fetal station describes like the relationship of the presenting fetal part to the maternal spine, which are like super important pelvic landmarks. So I would locate the spine with my examining fingers, so that would be going this way toward the well, actually, I'd be going down, and then I'd be swooping in with my fingers to locate the fetal positioning, like more than likely the head, right? Because we're not going to birth any other baby if it's breech or transverse. So station would be like 0, 1, 2, -1. If the client is like 80% effaced, then I don't know, we probably would be at like 0 station. And that's sort of like a midwifery hack is like, these are your stations right here. That's kind of how you know. Yeah, that's like the best I can probably describe stationing. And then obviously we're assessing fetal position. So when we're assessing station, we might be able to. It's not always necessary to find the fetal position, especially if by palpation we know where the baby is. Like, we would probably know if the baby is anterior or posterior or whatever. And sometimes that doesn't always matter unless we're feeling a face or like a brow, because then like that sort of flexion is like important for us to know. But if this labor is like not like a prolonged labor, then it's very likely that the baby is OP, posterior to the, I'm sorry, OA. So, but sure, if a client wants to know what the position of the baby, we'll tell them like, yeah, the baby's posterior, anterior, or face presenting, brow presenting. Sometimes those things matter if the labor is super long, and then sometimes it just matters because it might be nice to know why the baby is looking super, super pink or has an odd looking shape of their head when they're being born or things like that. A lot of the times it has to do with like, wow, this labor's like taking a long time. Oh, it's because it's a face presenting baby, or because the baby is OA. So then we tell the client, okay, we give the client all that information. We tell them what it means. We don't necessarily want to tell them like how long they have to go. And it's just like, you're doing really good. Progression's good. You were here 10 minutes ago, 30 minutes ago, an hour ago, and now you're here. So we are progressing. Things do look good, because a lot of times clients want to know like, is anything happening at all? Am I doing this for any reason besides just like, writhing in pain? So those are why like it's really good to offer a vaginal exam, but not press it. Because a lot of clients, they want it, and a lot of clients don't. Especially if they've had a baby before, they're like, it's all good. So after that, we are removing our gloves, throwing them away, giving our client encouragement and support. We're charting all of our findings, and we're also communicating to our health team what happened, and that's how we continue routine, appropriate, and respectful care to our client. Yeah, that is the conclusion. Thank you so much.